department, I was able to get a handle on things, and my slides have grown to more than 60, so I'm going to try to get through all of them. Just to start off with, we can't do awesome pregnancy research without awesome pregnancy research staff. And I'm showing you in my opening slide, Shama Khan, who's in the middle, and many of you know her. She is our research study manager. She has been here, I think, with us for more than a decade, and has Dr. Sauer mentioned shepherding, but she has shepherded us through much of the research I'm going to describe with you today. On Shama's left is Vanessa Martinez. She is a more recent addition to our group. She's been here, I think it's been a year, and I don't remember exactly how long. And Vanessa has been doing tremendous work, and I'll talk to you about some of the stuff that she's been doing. And then Andrea Prado currently is a volunteer, and I made a plea to Myrta the other day. We need to get her on staff and paid and full time. She's an MD who trained in Argentina. She was actually born here. Her father was a neurosurgeon, and she's been doing great stuff since she's been here, and we want to get her on full time. Okay, so these are my disclosures. I'm going to talk to you about a lot of industry-funded research today. We have NIH funding for a lot of the work as well. I'll talk to you about Jess Field's thesis project and the thing I'm most passionate about, which is the sulfasalazine study, which has started, and we'll tell you a little bit more about it here. Another disclosure is I'll be discussing a little bit of the work that our fellows are doing with Dr. Anant, but I'm not discussing any of the amazing NIH-funded research that he's been doing, and he has 3 R01s that he's currently working under that he's the principal investigator, and that's amazing and worthy of a whole nother talk. Another disclosure is that I invited my family, who said if they logged in, they would do so with aliases. My daughter may log in with the alias Joseph Albert Nefario. I'm not sure if you guys remember who he is, but he's from the Minions movies. This is also most of the work that we're doing, but not everything. Dr. Sauer mentioned that I was asked last week to do this talk, and I think that's happened a lot in our division, like when somebody goes out on, a speaker can't make it because of personal crisis, or we just didn't schedule somebody that week, which is rare. It's usually, hey, Todd, can you give a grand rounds? And the analogy I like to make, I like doing this. Many years ago, I took my family on a vacation to Niagara Falls. I'd forgotten to plan the vacation. I told my family I had, and I surprised them at the last minute with a last-minute plans to Niagara Falls, which turned out to be a great vacation. I'll show you some pictures of that vacation later on. This is a picture of the falls and all the mist that you see in the rainbow. And this is a boat called the Maid of the Mist. And yeah, it was just a great fun vacation, kind of spontaneous and random. And hopefully I'll give you guys a good experience today. We'll be talking about what studies that we've recently completed, studies that are currently active, some that are starting soon, and we have a bunch in that category, and then some stuff we are thinking of doing. A lot of the work that we do, and a lot of the studies that we get, many of the funded studies come through the Perinatal Research Consortium, which is a 10-center consortium with 12 maternity hospitals. We actually contribute to the Rutgers branch of this consists of us and Newark together. We're one site, RWJMS. And then we have a number of academic centers like Columbia and Yale and Mount Sinai, and then we Temple, and then we have a number of community hospitals, including St. Peter's nearby and Christiana, and together we're doing a bunch of work. This slide needs to be updated. This slide's from a few years ago with the $20 million. I think it's substantially more than that now. 45,000 is the right number of deliveries. What's super great about this group and what makes it attractive, both the NIH, actually this is a requirement if you're doing multi-center studies, you need to have a single IRB and then a single contracting mechanism. And we were ahead of the curve with this one. This was Ron Wapner's kind of brainchild, and he put this together well before anybody else has, and it's really served us well. One of the studies we did through the consortium is the Pearl study, which was a study of the JADA device. We know that one of the biggest problems facing our pregnant patients and one of the leading causes of maternal morbidity and mortality is postpartum hemorrhage. Much of that postpartum hemorrhage is due to uterine atony potentially after a long labor, potentially after infection. I'm not sure if you guys know that we participated in this study. This paper is published. This was published in about 2000 in the Green Journal, and it's had a major change on the way that we practice medicine in obstetrics in the US. So for example, this device has now been implemented in all the Robert Wood Johnson Barnabas hospitals and a full third of maternity hospitals in the country. Whenever we're doing clinical research, our goal, our hope is always that we will be able to impact the lives of women, and babies that we've never met before, that we can improve the level of care across the country. And I think this study meets that benchmark. I've been, engaged in research in one way or the other for more than 20 years. And I think it's pretty rare that I can say that we've met that goal. I think this study does that. When we have problems, we should never say they're intractable. And the way this study got started was that there was just like an idea generator or a think tank at Cal Poly in California. And when they asked some 18-year-olds, like, hey, this is the problem with postpartum hemorrhage, this is what caused it. And they said, what do you do? We're like, well, we give medications to make them contract, and we put a balloon in their uterus and we try to tamp out the bleeding. They're like, that's stupid. You just need to make the uterus contract. And they came up with this idea, the engineers got to work, and they developed a device that, if you talk to the docs across our system, they're like, this has changed what we do. And I think some of us here feel the same way. So pretty exciting. Okay. Another study that we participated in that was published more recently was the CHAP trial. And you guys know that this was a randomized controlled trial looking at different blood pressure targets, with the idea of if we moved the blood pressure target from 160 over 110, which was the ACOG recommendations, or 150 over 100, down to like 140 over 90, which was more typical at the time this study was started, can we see an improvement in outcomes? And this paper, published in the New England Journal of Medicine last year, showed a reduction in the incidence of preeclampsia before 37 weeks. There was less, with a composite outcome of preeclampsia with severe features, medically indicated preterm birth, less than 35 weeks, placental abruption or fetal or neonatal death. There was a significant reduction of about 20% in those outcomes. And that's pretty amazing. This is a study that, like, I'm getting worse and worse at predicting these things that I thought would not be a positive study. I don't understand why that would work, given that this is not the cause of preeclampsia. But I think what the study did was it allowed us to, we blunted that physiologic rise in blood pressure at the end of the pregnancy. Doctors were following guidelines and delivering patients early, but this kind of weeded out those patients who really didn't have preeclampsia, and we got them further in their pregnancies, and they and their babies were healthier. This was kind of great. On the day this paper was released, both MFM and CHAP and ACOG came out with joint statements. They were slightly different, but basically said that you should change what you're doing. And this led to an immediate change in practice across the country. This paper was labeled as like one of the top 25 most impactful papers by, I think, the Institute of Medicine just recently. And Alan Tita, who was the principal investigator of this study, is doing amazing things. He just had another first author paper in the New England Journal of Medicine about antibiotic use in certain situations in pregnancy. And we were super happy to be part of that. We have a bunch of follow-up studies, one of which we're just about to start, called the CHAP maternal follow-up, where we'll be looking at long-term outcomes in these women 5 years out to see whether they have more or less cardiovascular disease. That is funded by the NIH. There's a child follow-up study, which we will be doing as well. And that is funded as well, but we're not as far in the process. That's a little ways from starting. But this will look at the outcomes for the children to see if they're different. Do we not just see a short-term benefit, which is what we saw in the original CHAP study, but will we see different improvements in the health of these children a few years out? There's a number of secondary analyses, and one of these was just submitted, like looking at how these changes in management affect breastfeeding. We have another paper that has gone through multiple revisions, and this will be on whether moving to a target of 130 over 80 makes sense. Like, while this was going on, while CHAP was going on over a 7-year period, which was interrupted by COVID, the recommendations from the Institute of Medicine and others changed that we should be targeting a blood pressure of 130 over 80, not 140 over 90 like it was when CHAP started. And we accumulated the data on that, and that paper is going to be submitted, I believe, next week. It was really fun. We had a bunch of issues with the paper about, like, we thought they were going too far, and the principal author listened, and she's changed it quite a bit. Another study that we completed recently was MomPod. This is Kim Boggess's study, and you guys heard her speak about this here. This was a randomized controlled trial of type 2 diabetics with who were treated with insulin or we added metformin to their regimen. And it looked at primary outcome of neonatal health. And the study was stopped just before it completed with 830 patients and was stopped for futility, not because of safety concerns. And there are some component and secondary outcome analyses pending. This paper was presented as a late-breaking abstract at SMFM in February. And this manuscript is being prepared. We've already seen the first revision of it, and we'll see the first version of it, and we'll see where this goes. I'm not sure where Dr. Bogus is planning on putting this in. I was really optimistic this study would show a major reduction in preeclampsia based on a really nice paper that looked at preeclampsia as a secondary analysis and a 75% reduction in women who were obese, but we didn't find the same thing in this study. This is another industry trial from a company called Materna Medical. It is the PrEP device, which is a device that is designed to try to lower perineal trauma in women undergoing their childbirth with their first baby. This trial was going full throttle. We were kind of doing great in this one, so much so that the company, the CEO, has asked me to speak to like their Series B investors, and I've given some talks about this study. The device is pretty simple, right? The premise of this is that when women deliver their babies, their cervixes tend to dilate pretty slowly. And it's uncommon. You got all the residents and all the obstetricians on the call know that it's uncommon that we see cervical tears. We see them, but it's rare. But it's the rule, not the exception, that you'll see perineal tears. Like, it's pretty rare that I see a patient who is having her first baby and doesn't get a first or second degree tear. So the idea behind this device is you slowly dilate the vagina over about an hour's time. We place this device in women who've consented ahead of time. They're 6 centimeters dilated. They have to have an epidural. And you'll see this device, which like the top half of this device goes into the outer third or the outer half of the vagina and slowly dilates the perineum, puts it on stretch, allows it to remodel, and perhaps that will change the incidence of injury. So this dilates to a full 8 centimeters, which seems fine, right? Because the baby's head is about 10 centimeters in diameter in the occiput posterior diameter. So this, and our patients have tolerated this well. We are just starting after a pause. There was one complication at another center that was fully thoroughly investigated by the FDA. They're allowing us to continue this trial as a minimal risk device. The primary outcome, I think, in this study is a smart one. All of our patients are getting perineal ultrasounds when they're done about 12 weeks out, 3 months out. And what they're looking for, like this would be like a normal architecture when we're looking at the levator ani muscle, levator anus muscle, levator ani muscle. This is nice and intact. But if you look here, there's a separation on this side. And depending on which study you read, this happens in about 20 to 30% of childbirth. And the hope is that we'll see less damage, less pelvic floor injury, and this hopefully will lead to less genuine stress incontinence later in life, less pelvic floor prolapse, and we will see how this study works. I mentioned before that one thing I mentioned was that I thought that idea from the Cal Poly students about the JADA device for postpartum hemorrhage was kind of brilliant and amazing. They're thinking outside of like the usual things where, oh, we can't fix this. It's been our problem forever. I think we should always be thinking about things that we can do that might be derivative. So for example, like talking about this study, this is Nicole DeMerchant on the right or left side of your screen. It's on the left side of mine. She is our fabulous nurse midwife who works with us in our high-risk clinic and spends time on labor and delivery with us on Fridays. Like she was telling me about all of the techniques that she and other midwives use to avoid that perineal damage. So the question is like, is it the obstetricians that are doing a bad job, or is this an unavoidable injury? So it'd be kind of fun to compare Nicole and her colleagues either to the device or maybe to obstetricians. And if you guys don't recognize this actor, this is the character Karina Del Luca from Grey's Anatomy. And I've never watched that show, but I was looking for famous obstetricians and she popped up. Put it in my slides. You guys know that the way we do genetic testing, both for ongoing pregnancies and for stillbirth, has changed pretty dramatically in the last 10 years or so. There were two kind of brilliant papers, one by Ron Wapner and the other by Uma Reddy, who are both at Columbia and both very active with us in maternal fetal medicine, UNIS Network, and with the PRC. And they show that we can find, we have, when we're doing this antenatally, we have a much greater detection rate for clinically significant genetic anomalies when we apply microarray compared to the standard karyotype. And when we do this for stillbirth, we get a much higher yield because we get answers more. You do not have to look at cultured cells, and B, we get more information when we do a microarray, and we have much greater detection rates for anomalies, and we get patients answers more. Very often the answer is this won't happen again, and that can be of great comfort to patients when they enter their next pregnancies. If we find something that they have that is heritable, we might be able to use techniques like Dr. Sauer would, like IVF with PGD, to make sure that the next baby doesn't have that same genetic anomaly. There's a more recent study in 2020 by the group at Columbia and others looking at whole exome sequencing, and that showed even a greater uptick in finding anomalies that may be responsible for stillbirth, again, giving women and their families important answers. There's a study coming up now that's, I think we're just on the cusp of starting, called LOST-seq. And this is going to take the whole exome sequencing one step further to whole genome sequencing. And we are super excited to be part of this. So women who've lost a pregnancy after 14 weeks and are delivering with us, whether by D&E or by induction of labor, will be eligible for this study. Our genetic counselors are super excited about this. Elena at one point told me that if we didn't participate in this study, that she would, I won't tell you what she said she would do. But we're excited for this study, not because it's bringing in any kind of significant revenue, but because we are able to offer patients a very expensive test at no cost if they consent to the study. So this has, again, the potential to change practice. We'll see where this one goes. This is just starting. We've actually brought this to our other RWJBarnabas partners. So all 8 maternity hospitals can offer this in one way or another. Like, we do this test, like, we are a site for the study, so our patients don't need to interact with anybody but us. The other sites can access this study by working with Columbia, and we've had them speak. We've had their group, the Columbia group, speak multiple times at our perinatal collaborative, and I think there's some real excitement about doing this, not just here, but across our entire system. Another problem that we're working on is neonatal alloimmune thrombocytopenia. This is called either fetal or neonatal disease. This is analogous to RH disease or hemolytic disease of the newborn. Instead of antibodies crossing the placenta from the mom to the baby to attack red blood cells, they attack the baby's platelets. And if they do that, the baby can become thrombocytopenic, and that can lead to intracranial hemorrhage and severe sequelae. So these are typical ecchymosis and purpura for a newborn that was delivered with thrombocytopenia due to NATE. And that was the brain of that baby as well. Sorry about the slides. We've gone through multiple iterations with this disease and how we treat it. Currently, the standard of care is to use steroids and IVIG in pretty high doses to downregulate the maternal immune system to prevent this disease from occurring. And on top of that, we will almost always do a C-section. This is a picture of an ultrasound-guided cordocentesis where we put the needle into the cord. We can draw blood back, assess the baby's platelet count, and see whether that baby is a candidate for vaginal birth, but we almost always just do a C-section. There is about a 5% chance that this procedure could lead to the fetus sanguinating, and we don't think that risk is okay. And we put platelets back, but there is a significant complication rate when we do this. We are engaged with a company called Rally Bio, and they are trying to develop a new therapy to treat NATE. And the therapy is actually kind of cool. What they want to do is like that maternal antibodies cross the placenta by using, there's a transporter on the placenta that will it binds the FC receptor on the FC portion of the IgG molecule and whips it across the placenta. And if we can actually block that and then prevent those antibodies from crossing the placenta, then maybe we can have an impact on this disease. There's work going on this for hemolytic disease of the newborn as well. This company is taking a really smart approach. They want to actually find out what the incidence and the natural history of the disease is. They're going to
collect samples from more than 30,000 women across the country. And once they realize what their, what women at the beginning of their pregnancies have the antibodies against the fetal platelets, and we see how many women become sensitized to their baby's platelets across time, then they'll say, okay, this is the problem. Let's see, does it make sense for us financially to develop this treatment? And then we'll move on to the therapeutic arms of the trial if it works. There's a bunch of work looking at soluble FLT to placental growth factor ratios as a predictor of preeclampsia. We do this all the time, right? We have a patient that comes to L&D, they have elevated blood pressures, maybe they do, maybe they don't have proteinuria, and we want to know, like, we have to rule out preeclampsia. And there's been a number of tests that we've been engaged with over time that have tried to help physicians guide therapy. And there have been other manufacturers. This one is by, oh my God, this is by Siemens. And they're using their technology to be able to measure soluble FLT and placental growth factor, both important agents in the genesis of preeclampsia. And so we were just getting started with this study as well. There's three, actually, I'm sorry, this one's been going on for a while, and they just reopened it because they need more patients in one of the arms, and that's in the ones with the pregnant females with a suspicion of preeclampsia, but not confirmed. They've been using the test to look for patients that look healthy and normal, those that already have preeclampsia, and those that we suspect preeclampsia in. That's the group that they're most interested in testing. I don't love this type of technology, and the reason I don't is because rule out tests are never really all that helpful. For example, there's fetal fibronectin is a test that we have that can rule out preterm labor or not rule it in. And when we use a test, on occasion, it's useful. Like I would say a few times a year, I use that test, but it is not tremendously helpful in managing our patients. There's always a very high negative predictive value with these tests, and I think clinical judgment is probably just about as good as this. We'll see where this goes. We've done at least 2 trials looking at different assays for the same thing, and none of those trials have resulted in a product that's come to market. And I think this one might be a little bit better, but we'll see. We've done a bunch of NIPS studies, so a bunch of non-invasive prenatal screening studies over the years. And we love these studies, not because it results necessarily in authorship for any of us, but we like it because A, these are important questions, and B, these generate significant revenue. Myriad Genetics is testing out a new technology. In addition to doing the standard NIPS, which looks for Down syndrome, trisomy 18, trisomy 13, and sex chromosomes. They are going to try to use their technology to pick up autosomal recessive conditions like spinal muscular atrophy and cystic fibrosis, for example. So right now we actually do a ton of testing for our patients. A lot of our patients receive genetic counseling. A lot of them choose these expensive tests that both look for autosomal recessive conditions. If you find those in the mom, you have to test the dad. Dad's not always available. And then we do the second test during pregnancy, usually around 10 to 12 weeks. To look in their blood to try to find out if the baby's got Down syndrome. This test would combine both of those options, and if that's true, that's kind of awesome. I'm excited about the fact that we might be able to combine tests, reduce costs, and this is a pretty good study. There is a grant process in the PRC, in the Perinatal Research Consortium. I've mentioned them a couple of times. One of the fellows from Yale, Emily Lee, has an ongoing study looking at monochorionic twin pregnancies and trying to assess cardiac strain in those pregnancies. Monochorionic twin pregnancies are really tough. They run into trouble all the time. Even when things are going really well, you can have an unexpected demise. You worry about selective IUGR, twin-to-twin transfusion syndrome. There's something called there's TAP syndrome, which is polycythemia, anemia, twin syndrome. I got that thing backwards, and they often just run into trouble late. This study does serial echocardiograms to look at this measure called cardiac strain, and we're trying to see if it will predict adverse outcomes later on. Emily Rosenfeld has done such a good job with this study that we've had to increase our the number of patients we're allowed to recruit. And because we are seeing patients in so many places now, I'm not sure if you guys know, but our practices stretch from Livingston in the north all the way down to Lakewood in the south. And we have, I think, 6 or 7 outside practices, and the MFM attendings that are in our group are working incredibly hard. And we're funneling some of these patients into our studies. And Emily, I don't know how she does it, but she tracks every single EMR. She tells me who I'm going to see at ChemEd in Lakewood before I'm even there. And she says, approach this patient. She's extremely good at that function, and she's been kind of killing it in that study. We have 2 new NIH-funded trials that I'm not going to give proper time to. These are both coming out of Columbia. The first is a study that was funded, given the grant was awarded to Alex Friedman at Columbia. The study is called Modeling Informatics Data to Track Maternal Risk and Care Quality. And the goal of this study is to analyze data from a large hospital consortium, that's ours, to create scalable informatics approaches across electronic health record platforms that can be used to improve clinical care. And a very similar study, but looking at different outcomes, was a grant was awarded to Uma Reddy at Columbia. And this is, we call this one sepsis, but this is a study that can we use AI and can we use other types of techniques to do better at identifying women with sepsis. A lot of the measures that we use and a lot of the flags that alert the rapid response team here at Robert Wood don't necessarily apply to pregnant women. If you have a patient on L&D, she's going to be tachycardic because she's pregnant and she's in pain. She's going to be hypotensive because she's pregnant. And these are triggers for sepsis. So we need to figure out, like, how can we do better in really identifying these women who might have sepsis before they deliver. And then we know that, like, there's this golden hour, right? If you give antibiotics in the first hour of the recognition of the condition, patients tend to do much better. You keep them out of the ICUs and you keep them alive. So this has a lot of potential. Just going back to the Niagara Falls theme, there's something, but you can actually get on that boat, the Maid of the Mist. I'm sure some of you guys have done this, but it's like Niagara Falls, even on the Canadian side, is like one of the tackiest places you'll ever go. There's like an Applebee's there that just keeps talking to you about how much you want a hamburger and you should come in right now. So there's some parts of it, but it's also like we've taken one of the most beautiful places on earth and we've totally commercialized it. But this thing, the Maid of the Mist, is so much fun. And this is my family both on the boat and then afterwards. This is Max, my son. Max is actually a co-author. He worked in our lab for 3 summers. He's on one of the papers I'm going to show you. He's also a medical student here, so he's come a long way. And this is Alex. He was a co-author on one of our papers after spending a summer here. One of our lab technicians, Natalia Probst, I brought them both into C-sections the first time without my knowledge. And Max didn't really care, but Alex put his head in a bucket after that and decided that medicine wasn't for him. So I think Natalia is directly responsible for Alex pursuing other things. I'm showing this slide this way about this probe that we use to predict preterm birth. This is the brainchild of Vladimir Igorov, who is the CEO of a nearby company in Princeton. And weirdly enough, he found us on LinkedIn. Like LinkedIn, I've never had anything useful come out of LinkedIn, like, you get job offers and stuff like that. That's pretty much it. But he found us and thought we'd make sense to work with us. He has developed a test, and this is not the only
Dr. Rosen, we have suddenly lost audio. Can other people hear him, or is it just me?
We don't.
Can you hear me now, Gary?
Yes, now I hear you.
All right, maybe I'm just talking too fast. So the cervical monitor is a device that measures cervical elasticity. We know that when women labor, their cervix shortens, but it also softens, right? That's one of the things that happens. So the less elastic the cervix is, the more likely it is that you're going to go into labor sooner. We ran a prospective trial looking at these measurements and seeing how well they predict preterm birth. I forgot about this study. I wasn't going to show it, but Dr. Igorov just sent the first version of the paper for me to review and to write the discussions. It'll be getting out soon. I can just tell you that this is not really news because other studies have shown the same thing. This was a topic of major interest at our most recent national meeting with the group, like I think the group from Tufts and others. Utah may be doing this work, but he was able to show that cervical stiffness does predict preterm birth, maybe better than cervical length. I'm still going through the paper to see how good that is. What else? There are many in our department, Dr. Bachman, Dr. Ayers, Dr. Sauer, Dr. Namp, who are involved in the New Jersey Kids Study. So these are pictures on the bottom of Dr. Maury Blazer, who is seriously like one of the greatest physician scientists on the planet with an H index of somewhere around 160. It's insane. He is working with Emily Barrett, who is an epidemiologist in our group as well. And they're doing this amazing statewide study called the New Jersey Kids Study, and they're going to be trying to figure out how the microbiome affects the health of children through their lifetime, but it starts during pregnancy. So the aims of this study are to start in pregnancy and recruit a diverse cohort of pregnant women from obstetric clinics across New Jersey. I think Dr. Ayers and Dr. Bachman did like the initial pilot study, and there will be another pilot coming up with a larger sample size this time in 2 sites, and the MFM division will be actually helping with that second study. We will see how diet and lifestyle and culture and all those things affect the microbiome and how that may affect child health, growth, and development. And that, like, I think this study has something like $6 to $8 million in funding, and that is just a start. Like once they get this thing started, I know Dr. Blazer and Dr. Barrett are planning to apply to the NIH for additional money, and this is like something that it's like kind of generational and could really give us tremendous information that helps us manage kids in the future. There's a study called ECHO, which is a long-term project by the NIH that stands for Environmental Influences on Child Health Outcome. And what they've been doing is collecting samples from other long-term ongoing maternal child cohort studies, and New Jersey Kids fits into that group. Dr. Barrett applied for funding through ECHO to do some additional work, and she thinks she's got, her score indicates that she should get funded. This is something I expect to be funded, and we're going to be working with, since this again involves recruitment of pregnant women, I think this will be another study that we have upcoming within the next year, give or take. We are, for now, part of the Maternal Fetal Medicine Units Network, and if you guys don't know that group, it's an NIH-sponsored group of now 10 academic hospitals. They've done a bunch of the work that has really influenced care in our specialty. Among the trials that have been published are the ARRIVE trial, which showed that elective induction of labor in low-risk nulliparous women actually results in better outcomes, so much so that some of our colleagues think it is unethical to not offer or even recommend an early induction. We definitely offer our patients a 39-week induction. I don't think it's unethical not to do that. Another study that came out of there, which I sort of hate, was the ALPS trial, and this study showed a minor respiratory benefit between 34 to 36 weeks. In children that were born in the late preterm period, if we give steroids, they have less transient tachypnea of the newborn, and there's some benefit to that. But we always worry about the risks of long-term steroids. I've given you guys a grand rounds, I think, when there was some other last minute cancellation recently. And we are actually one of about a quarter of centers across the US are not doing this, but 3/4 still are. There was some nice safety data presented by Cynthia Giampi at our last meeting that showed that the babies who got steroids at age 5 did not have cognitive deficits, which is the concern, but they haven't presented whether there's long-term benefit from this intervention. Unless they show that, like, I'm not so excited about it. We are running 2 trials with the MFMU right now. We're a Columbia subsite. One of them is sleep, and I really like this trial. I think this one's pretty exciting. And Vanessa Martinez has done such an amazing job on recruiting patients, which is not an easy thing to do. What she does is if a patient meets criteria for entry, she offers them a CPAP machine, and we assess whether they actually have obstructive sleep apnea. And once we've done that assessment, they get randomized to either CPAP or normal care. And there's some data, but that needs to be replicated, that this may reduce the incidence of preeclampsia and other hypertensive disorders of pregnancy. Vanessa's done such an amazing job in this that she is out recruiting all the other Columbia sites, I think combined right now. That given that we are a small site, that means we're punching above our weight, and they have been super happy with us. And Vanessa is just, I don't know how she does it, but she's amazing. A study I don't like, if I hear about another study about progesterone, or I hear about another study on pessaries, I'm going to lose my mind. We are running a weird trial that was funded and it's going on through the MFMU of a trial to compare progesterone versus a special type of pessary called an Arabin pessary in women with twins that have a cervical length of less than 30 millimeters. There was just Matt Hoffman from Christiana, who's one of our colleagues in the PRC and just amazing. He gave one of the leading talks, one of the plenary talks at SMFM this year about doing this in singletons, and it didn't show a benefit. I'm wrong about everything, but I'm no way optimistic that this will show a benefit in our in twins either. But maybe this will finally put that to rest. So there's some value there. More pictures from our fantastic vacation. This is from about 13 years ago. This guy is 27 now. He's 24. My daughter is driving now, and which is an interesting experience. Some of you guys know that my daughter likes to make driving sounds. Like when she steps on the gas, she goes, when she turns, she has a turning sound. And I'm trying to teach her to drive stick right now, which is an experience. Let's talk about our fellow's thesis project. Emily Rosenfeld, pictured here on the right, and Deepika Sagaram, one of our fabulous junior faculty, are running the MOP study. That's the management of postpartum preeclampsia. And what we've seen in our practices across the maternity hospitals at RWJ is way too many women being readmitted or seen in the emergency room for elevated blood pressures postpartum. We know that stroke and other complications from hypertensive disease are one of the leading causes of maternal morbidity and mortality across the US. We'd like to do a better job in managing this. So what Emily and Deepika are doing is they're doing two things. One is that they are lowering blood pressure targets from the current ACOG recommendations of 150 over 100. I'm sorry, 160 over 110 is when we start meds now. I think I'm right about that. I'm probably wrong. And then we're lowering that blood pressure to 130 over 80. So we're going more in line with the national guidelines for treating hypertensive stage. We want to get them down below 130 over 80. And second is we're using technology, and this has been like really generously donated by RWJ Barnabas. We are using remote blood pressure monitoring. Patients we've done some patients already, and they've been very compliant with this. It's been kind of great. We have real hooks into how they're doing, and we're going to see, can we reduce emergency room visits? So I think just doing the blood pressure monitoring would increase ER visits, but if we combine this with trying to with tighter blood pressure control, we'll do better. We'll see how that works. That study, that Deepika's applying for R01 funding for that, and she'll run that through the consortium and other centers. She's actually presenting to the CHAP consortium, I believe, either at the end of this month or the beginning of next month. Alan Tita has been interested in this study as well. And right now, Emily's running the pilot as her thesis project. I'm going to show you just like a couple of, there's a couple of things that I just wanted to highlight. This is a study that Emily has done with Dr. Ananth, looking at chronic hypertension and the risk of readmission for postpartum cardiovascular disease. This is like a variation on a theme, but they're using population-based data to do this work. This work is already developed a manuscript and it is under consideration. Dr. Ananth is really optimistic this will get published in a top journal, and like he's doing so much more. I'm just going to show a couple of things that they're doing with him, but this is a big part of what our fellows do, and he adds so much to the work that we do in our department. This is Jess Field's thesis project. And this is the one perhaps I'm most passionate about because it's a therapy against preterm birth, trying to prevent recurrent preterm birth, that is based on like the 10 years of basic science research we did in our lab. Like this is an especially time to do this because the treatment that we've used forever, or not forever, but since like 2001, for prevention of preterm birth, which is 17-alpha hydroxyprogesterone, since 2003, had a big trial called for long published back in 2019 that showed no benefit. And like there's been 3 years of wrangling over whether this drug should continue to have FDA approval. I'm not sure if you guys saw in the Times 2 weeks ago, but the drug was pulled. This is my big beef with a lot of the things that obstetricians do is we say, hey, it makes sense that progesterone is a pregnancy maintenance hormone. And so if we give more of it, everything should be fine and we should see an effect. But that's not enough science. And we have trouble doing studies on pregnant women. And sometimes we're boxed into a corner by our, by outside forces. But we have never really been able to show in any way that Makena 17-alpha-hydroxyprogesterone is a great therapy. When we tried for everything but this one big study that looked very promising, we've never been able to correlate drug levels with effectiveness. We've never been able to show that it helps in twins or triplets or in patients in preterm labor. It was just very specific for recurrent preterm birth, and that didn't make a lot of sense. Part of the problem is that there's so many reasons for preterm birth, like the uterus can be overdistended with twins, or there can be infection, or there can be bleeding. There's lots of reasons. The two that we're super interested in are both stress and these unknown preterm births. More than half of women that deliver preterm, you cannot find a cause. And we think that's probably due to abnormalities in the timing of labor. And this is what we studied in our lab. Basically, we were trying to understand how the placental clock worked, meaning that we know that there's a clock that starts ticking probably sometime in the mid-trimester. And when it goes off, like an alarm clock, labor starts. One of the hormones that we know is tied to the timing of labor is corticotropin releasing hormone. That's the same hormone that's made by the brain, but it's also made by the placenta. It's funny, the brain makes a bunch of neurotransmitters, and we've actually hypothesized that the placenta is smarter than we think. The placenta makes decisions, and we think the placenta largely decides when the baby comes out. We think there's actually two major mechanisms by which that happens. My place this one out. Technology here. We think that number one is that the baby puts the placenta on stress as it grows. Like the fetal to placental ratio keeps increasing as gestation advances. The placenta is smart enough to know its main job is to give the baby what it needs. And if the baby's getting too big, it can't do that. That puts the baby under stress. That makes this molecule called NF-kappa B. Or this is actually NF-kappa B2. And then when the baby is ready, we've actually shown in some of our studies that it produces some substances from the lung, and that can cause NF-kappa B activation. We ran a study, this is back from 2018, and this was with my partner Bing Bing Wang and a bunch of other people, including the amazing Max Rosen, where we screened more than 1,200 small molecule inhibitors to identify NF-kappa B inducing kinase, a key enzyme that activates this process. And we found that sulfapyridine, which is part of sulfasalazine, is actually very good at knocking down the enzyme and knocking down its action. We showed that it crosses the placenta, that it's present in cord blood at about the same levels that we saw in vitro. So we're optimistic that this will work, and that's the basis for Jess's study. There's some epidemiologic evidence as well that shows that there's more than 240 women that got sulfasalazine as part of these studies. It's actually 281 patients. And really interesting, there are no births in either of these studies in women getting sulfasalazine before 34 weeks. These were secondary outcomes in both of these trials, so you always have to take it with a grain of salt. But I think between our laboratory evidence and this retrospective data, there's good reason for this trial. We have FDA approval for the trial, so we have an IND. That is really not easy to get during pregnancy for a pregnancy trial, and we have IRB approval, and we are actively enrolling in this trial. I'm not going to show you the rest of the slides for sulfasalazine because I'm running out of time, but that is something that we're doing.
Dr. Rosen, I suddenly can't hear you.
How about now?
Yes, now I hear you.
Weird. It's not me. Okay. Ruby is doing a study, and this is with Dr. Ananth as her principal investigator. And this is Ruby's idea, and I kind of love it. She is going to be looking at obstetrician and midwife density and comparing that to maternal morbidity and mortality. And that is a major project. Sorry, go back one. technology failure. There are maternity care deserts in the US, and this is becoming worse. If you guys have been seeing the Times, a lot of rural maternity hospitals are closing. Hospitals just don't feel like they feel like they're money losing services when their volume is too low, and that's true. And I think we have to do something about this as a nation. But what Ruby and Dr. Nanth are going to be doing is looking at county level data. And there's a lot of counties, and this is a tremendous amount of work. Dr. Nanth said he would only do this with Ruby if she made this her thesis project. And I think there's real potential of this project. And I'm also curious about what they're going to find. Like sometimes when there's fewer doctors, outcomes are better. I'll bet you that we find the C-section rates are substantially lower in the maternity care desert because patients will get to the hospital for a planned C-section and already delivering, stuff like that. So we'll see what she shows. I'm hopeful that we wind up showing that we're doing a good job, but I wouldn't be surprised if the data is mixed. What else do I want to show you? Yeah, I mean, we're doing some small things too. Like, I'm not sure if any of you guys know what the Muller-Hillis maneuver is, but it's something that I learned to do as a resident. If we're trying to determine whether a woman is going to deliver vaginally or not, we can give fundal pressure while doing a pelvic exam at the same time, and we can see if the head descends. It's kind of funny how it was named. Muller did this maneuver in 1885 where he pressed on the fundus and somebody else did the exam. And then Hillis said, let's do something different. Let's put fundal pressure and pelvic exam by the same examiner. Like, not really brilliant stuff. It's probably why nobody remembers the name of the thing. I actually even called the chief resident who taught me this when I was a resident. I said, hey, that thing you taught me, you knew the name of it. What is it? And he forgot. And then like using Google, I was able to find that. There's been a couple of papers published on whether this thing works or not, or whether it's effective. I do it before I place forceps. I've always found it to be useful for that, but not universally accepted. And when I've described this to my colleagues, they're like, what? Huh? This is Alexandra Cortella, who's got the redhead on the left side of this picture, and Vanessa again. And we're going to try to standardize exams by using a pelvic model. And that's the major innovation here. We're going to look for inter-observer and intra-observer variability. After teaching our residents to do this work, I don't think I've told the residents we're doing this yet. And we are developing a data form for EPIC, which we'll be able to use to track some of the data, including whether the Muller-Hillis was positive or negative, in addition to like looking at the estimated weight and some other parameters to see if this actually is useful. And I'm excited about this. Like, Alexandra is crazy. She has decided that she is going to do a prospective observational trial during her medical school years, and she's written the IRB, and she has made a presentation to our research meeting, and I think this is going to work. I'm very hopeful that she'll be able to collect this data and show something meaningful. That one's unfunded. We have a presentation today to LabCorp to look at prevention of preterm preeclampsia using first trimester multi-marker screening, and I'm super excited. So Nanth, Joy London from our budget office, Emily, who's done a lot of this work, Emily Rosenfeld. We've got some help from our friends at Columbia, like Stephanie Lynch, who's the PRC coordinator, will be there. And and Suzanne Spurnell, representing the system, will be there for this talk as well. So right now, our standard of care for trying to prevent preeclampsia is to use ACOG clinical risk assessment. So if a patient has one high risk factor or two moderate risk factors, we will start or consider at least low dose aspirin if the patient has more than one moderate risk factor or one or more of the high risk factors. That's not terribly effective. At best, we reduce preeclampsia by about 10%, and that's preeclampsia before 34 weeks. There's been work done primarily in Europe by Nicolaides and his colleagues, and they've done this multi-marker screen, which includes looking at demographic factors, doing some blood work, which is PAP-A and placental growth factor. Actually, not AFP. I'm going to have to take that out of this slide before we present. We measure in a very standard way the mean arterial pressure, and the way you're supposed to do this is have a patient sit 4 or 5 minutes with her legs in dependent position, arm up at the level of the heart. It should be the left arm, and you take the pressure that way. It's what we should be doing in all of our practices, but we don't. And then lastly, we're going to be measuring uterine artery Doppler pulsatility index. And that screening in European studies by Nicolaides has been shown to be very effective in predicting preeclampsia. They can predict 90% of preeclampsia before 34 weeks and 80% of preeclampsia before 37 weeks. Not so great for term preeclampsia, but we care much more about the preterm preeclampsia. There was a trial done and published in New England Journal of Medicine back in 2017, and that showed that using this strategy, they could reduce preeclampsia before 34 weeks by not 10%, but by 80%, and by 60% before 37 weeks. Like, it's really interesting to say, is this really true? I don't know. But what I can tell you is that Nicolaides, everything his and his group have ever done, they're super innovative, super careful scientists. And he said using nucleotranslucency to predict Down syndrome with these blood analytes was going to work, and we verified that in this country. He's published a ton on every other topics. He's, in my opinion, the premier maternal fetal medicine researcher in the world, and I think there's good reason to think that his data will bear out here. But the problem is that nobody's doing this in the U.S. We proposed this study to a different company, which kind of is a long story. But when I was doing that, I put out a poll on the SMFM Facebook website. So I asked, are you guys actually using the screen because it's commercially available? And the answers were kind of all over the place. Like, the kind of more evidence-based people were saying, like, yeah, we use this, we do the screening using our standard tools, and we give aspirin if they need it. Other patients said, other MFM said, well, all of our patients have something, so we just give universal aspirin. One doctor said, well, if there's a history, I give it 162 milligrams. If there's no history, 81 milligrams. A kind of a funny story. And then I think we found one person who was actually using the screen, and they gave 162 milligrams. And this was not scientific, and not that many people responded to this poll, but it's pretty interesting. So what we're proposing to them is an RCT with about 12,000 patients screened for preeclampsia. We're going to randomize half of them to the ACOG protocol and half of them to the multi-marker screen. We will treat those who screen positive in each arm by which test that comes positive, and we'll see whether there's a difference. If this works out, it could lead to a major change in what we do. And what I think the study is important is because if we use faster and first trimester Down syndrome screening as a historical interest, then even though the data was really strong from the European studies, the first trimester screening didn't gain widespread acceptance until the US did the trial in our population and showed it was just as effective, and we need the same sort of confirmatory study here on this. Okay, so that is it for me. That is the end of the vacation, and Alex was super happy at the end of our vacation. This is Alex from 12 years ago. If you guys have any questions in the remaining 5 minutes, sorry about going so long, I'm happy to take them.
Thank you, Dr. Rosen. Thank you for that excellent review. Are there any questions? So I have a question about the obstetrical care deserts. It seems very difficult to tease out all the different factors that could be contributing to morbidity and mortality in those areas. Certainly, it might be the distance they have to travel to get good care, but it also could have to do with the poverty or other socioeconomic status of people who live in areas that are remote. It could have to do with nutrition. So how will you be able to draw the conclusion that it has to do with the distance from available care?
So that's a great question, and one that Ruby and Ananth are going to have to answer. So not my project, but basically what you do is multivariable regression analysis, right? They're going to look at only one of the factors will be, again, on a countywide basis. It's really hard to do, how far you are from the hospital. And then they'll also be looking at, like, what are the differences in the population? Is there more obesity? Is there more hypertension? They should be able to get all that data from their tools, and they will try to make their best guess at what role lack of obstetric providers play. I'm not answering this well in that question. So depending on how robust their data set is and how sophisticated analysis they are doing, they will be able to answer that question with either a high degree of certainty or a low degree of certainty. And we'll just see where that goes. They're just starting out on that, Dr. Ebert. I don't think I see Ruby on the call. Maybe she's in another room with one of the residents or one of her co-fellows, but I'm sure they will be considering those issues.
I see Dr. Alakunis has her hand up.
Hi, good morning. Thanks, Todd, and thanks, Gary, for putting this together today. So many wonderful research projects you're involved in, and great for all of us to know what you're doing. I'm particularly interested in the preterm birth study, or I don't know, you maybe just looking at CRH levels initially for the sulfasalazine. Are you going to be looking at drug levels at all in that study to kind of correlate exposure to changes in CRH or any other outcomes?
So, Lauren, hearing you ask that question, I feel like an idiot because I did not even think of measuring drug levels. The first study that we're doing is a pilot study that's powered to detect a difference in rate of rise of CRH across pregnancy. So I zipped through those slides, but we're going to be starting therapy at 24 weeks of pregnancy and continuing the drug up until 36 weeks. And we'll be measuring serial CRH levels across the gestation 24, 28, 32, and 36 weeks, and then we'll be stopping the drug. And what we hypothesize is that we'll see a lower rate of rise in CRH in the patients who are getting the drug. We are going to be drawing a bunch of blood samples, and we will have those samples to measure sulfasalazine levels, but I didn't even think of doing that. And now we have limited funding for this study. Like we have like $30,000 to do it, but we're certainly equipped to do that. And maybe what we'll do is if I can scrounge up some money somewhere else, if we see a difference in CRH levels, it would make sense to measure sulfasalazine. And what I'm going to do is bother you in the future to run the whole study by you and say, this is what we're doing. What did we do wrong? And thank you for just a super great question. But yeah, I'm going to definitely torture you. We're just getting started on this.
So, the reason I'm also interested is because sulfasalazine is a substrate for one of the key placental transporters, and for which, we see genetic variation during pregnancy, both in the placenta, but could also affect overall. So I think there might be an interesting tie. So I guess my other question is, are you collecting DNA in the pilot study to look at any genetics?
Absolutely not our plan at all. But again, what I'll do is if you're okay with it, Jess and I will come talk to you and see what your thing is. As far as I know, so first of all, sulfasalazine is two drugs, right? It's 5-ASA and sulfapyridine. And 5-ASA stays in the gut. Sulfapyridine actually makes it into the bloodstream. And what studies have shown is that drug crosses the placenta. You can very reliably measure sulfapyridine levels in the cord blood. And the levels that we're seeing in the cord blood are very similar to the levels that we saw our effect in vitro. So I assumed it was not a substrate, that it was not affected by placental transporters, but you can tell me more. Again, I'm going to ask to set up a meeting with you and Jess, and we'll go over all that stuff. And you can tell us what we forgot to do. And since we're just at the very beginning of this, we haven't even drawn the first blood sample. We've enrolled like 3 patients who volunteered to be in an RCT, which I'm excited about. And that's all been in like just a couple of weeks. We still have time to fix what we broke, but we didn't think of. So thank you.
Yeah, I think it's the idea is that maybe we could overlay just heterogeneity amongst pregnant people and outcomes, because in case you see non-responders or those are not affected, I think it could also be due to gut absorption of the sulfasalazine as well. So we'll talk. We can write a second grant to get that funding for the PK aspect.
Perfect. Thank you.
All right, well, we're just about out of time. So Dr. Rosen, thank you so much for filling in and giving us all of these exciting projects to look forward to.
And thank you for having me.
All right, well, we're going to have to end it here. So I wish everyone a successful and fulfilling day.